Cardiovascular alterations, part 4, rheumatic fever and rheumatic heart disease are due to, more than likely, a group A, alpha beta hemolytic streptococcus, the group A, beta hemolytic streptococcus. This will cause an inflammation of your joints, the skin, the nervous system, and the heart. It could also be familial. You may have a genetic predisposition to it. But rheumatic heart disease occurs due to untreated rheumatic fever. And you'll have, so it's a sequelae or a consequence of an infection in the nose, pharyngeal infection, immune response to cell-mediated antigens. It results in diffuse, proliferative, in other words, it spreads, exudative lesions. Carditis is an inflammation of the heart, so you'll have a murmur and chest pain. Polyarthritis is a transient inflammation of your large joints, so that will also have pain. Chorea is a sudden, aimless, irregular, involuntary movements. Erythema is redness. Marginatum means you have a rash on the trunk, so you have a red rash on the trunk. Exudative synovitis means that you have heat, redness, swelling, severe pain, and tenderness in your joints. Infective endocarditis used to be called SBE, or subacute bacterial endocarditis. There's a flow sheet on page 646 that talks about this. You'll have the endocardium that's damaged. Organisms will attach and grow to the endocardium, which is what forms your valves, and it'll cause what are called infected vegetations or colonies on those valves. It can be acute, subacute, or chronic. Symptoms are due to infection and inflammation, the systemic spread of the microemboli, and the immune complex deposits. You'll have fever, a murmur, and petechial lesions that can occur on the skin. Risk factors are IV drug use, being a male, having a ventricular septal defect, a prosthetic heart valve, acquired valvular heart disease, or long-term IV use, which could be even therapeutic IV use. The conduction system. This is the normal conduction system from the SA node to the AV node. This is your PR interval. Normal PR is 0.12 to 0.20 seconds. Then it continues on from the AV node to the bundle of His and to your Purkinje fibers, to the myocardial cells. This is your QRS complex. Again, normal is like 0.04 to 0.10 seconds. Your ST segment is normally isoelectric. Your T wave is normally upright. And isoelectric means it's on a straight line on the level of the baseline. And that's isoelectric, L-E-C-T-R-I-C. It's not isoelectric. So when you interpret your rhythm strip, you look at the complexes, your time frame. And the squares are all the way across. And as you keep going across, each little teeny tiny little square is 0.04 seconds. From one dark line to the next dark line is 0.2 seconds. Each teeny tiny little square is 1 millivolt of time, 0.1 millivolt. And so it's also 1 millimeter. So each little tiny line going up is 1 millimeter. So here is 5 millimeters. Okay. You need to look at your P wave initiates atrial contraction to the PR is when you have atrial contraction. QRS is from the Q point, not the R wave, but from the Q point to where the S returns to the baseline. And your QT interval is from the beginning of the Q point to where the T returns to the baseline. ST segment, as I said, is normally isoelectric, and your T wave is normally upright. If you have a U wave, it indicates an electrolyte imbalance. This again is showing the different intervals that go along with the norm. And remember, QRS of 0.10 is still considered normal, and the different intervals that go with that. And this is from the memory book that's looking at the P wave and how it looks at each one. This is another way to help you remember. how to calculate your R waves. You want to count the number of R waves in 6 seconds, or 6 large blocks, and multiply by 10. That's the quick and dirty method. The best way to do it is to count the number of teeny tiny little squares between one R and the next R wave and divide it into 1,500, because there are 1,500 teeny tiny squares in 1 minute. So if you're in a hurry, you can do the quick and dirty method of counting the number of complexes in 6 seconds, which would be, and then multiply by 10. But, okay. So disorders of heart rate and rhythm. Usual cause is ischemia, electrolyte imbalances, or disease. You can have an abnormal rate of impulse formation. So this would be bradycardia, where your heart rate is less than 60, or tachycardia, where your heart rate is greater than 100 if it's initiated in the SA node, and greater than 40 if it's initiated in the ventricle. You can have fibrillation, which is where you have a quivering of that chamber. There's no adequate contraction. And if it's of the ventricle, the patient's effectively dead because there's no cardiac output. If it's in the atria, it will decrease your cardiac output by 15 to 25%, and it increases the risk for embolism formation in either instance, because blood will pool. Anytime blood pools, it clots. So when the heart starts to contract again, you'll have the risk of sending out blood clots. Atrial flutter will cause sawtooth type waves. Like if you look at the edge of a saw, you'll see how irregular those are. And that sawtooth waves, again, will decrease cardiac output if it occurs in the atria, and again increase the risk of embolization. If it occurs in the ventricle, again, your patient is basically dead, and there will be no cardiac output if you don't do CPR and defibrillation. If your patient is asystole, it means you have no contraction at all. Again, somebody dead. You need to do CPR, but not defibrillate. You can also have an abnormal conduction of the impulses. In other words, it goes different places from what it should be. A sinus block indicates a contraction of the atria with no resultant contraction of the ventricles. So it would be like an APB, atrial premature beat. An AV block means that there are more atrial contractions than ventricular contractions in a coordinated fashion, so that you will always have one more P wave than you will have QRS if you're talking about a second degree AV block. First degree AV block just means that your PR is prolonged, greater than 0.20 seconds, but it still could be very regular, and you will have a QRS for every P wave. Second degree AV block, your PR will get progressively longer, and then you'll drop a QRS. Or your P wave remains constant, but you still drop a QRS. And this will occur in a coordinated fashion. In other words, 4 P waves for every 3 QRSs, or 3 P waves for every 2 QRSs. So you'll have an irregular rate. Third degree AV block means that there is no connection between the atria and the ventricle, and you have atria doing their own thing and ventricles doing their own thing. They're not really talking to each other. It's also a medical emergency, and you need to make sure that this person gets a pacemaker. AV dissociation, again, means there's no conduction between the atria and ventricles, and it's a type of third degree AV block. An intraventricular conduction delay is the new term for a bundle branch block, because it indicates that it's no longer could be due to just a blockage in one of the left or right bundles that causes the problem. But it's prolonged. It's taking longer for the conduction to get from the AV node to the ventricular cells. And it's a new term that's used because it's not always a blockage in the bundle branches that's causing prolongation of your QRS. It could be medications or an electrolyte imbalance. You'll still see bundle branch block used. But all disorders of heart rate and rhythm cause a decrease in your cardiac output. Now, if you look at this, the top tracing right across is just a lovely regular sinus rhythm. This is showing you an atrial flutter. This is showing you an atrial fib, another atrial fib. This is showing an SVT, or a VTAC. depending, and this is VTAC, VFib. Yeah. Sinus bradycardia, sinus tachycardia. Only thing that's different is that the heart rate is faster. This is ventricular tachycardia. You can see the QRS is whiter, more bizarre looking. Ventricular fibrillation, coarse fibrillation. It's a continuous strip, not doing too well. Patient theoretically dead unless you do something about it. Heart failure is also called pump failure. It's the inability of the heart to supply the body and heart muscle with an adequate volume and pressure. If it's right heart failure, it's sometimes called backward failure or cor pulmonale. Cor pulmonale means you have right heart failure due to lung problems. Symptoms: jugular vein distension, increased peripheral vascular resistance, increased central venous pressure, liver engorgement, because fluid will go into it. An increase in hydrostatic pressure will cause edema and anasarca is total body edema. So around the eyes, of the face, the hands, the abdomen, as well as the legs. It can result from left heart failure, but the usual cause that when you have pure right heart failure by its own is pulmonary hypertension. But both will increase pulmonary vascular resistance. And this is a flow sheet showing right ventricular failure due to lung disease, where you have the decrease in oxygen supply that causes hypoxia, decreases the force of ventricular contraction, increases right ventricular end diastolic volume, pressure, preload, increases preload, causes peripheral edema. So your symptoms for right ventricular failure: increased peripheral venous pressure, ascites, liver. Patients with right ventricular failure can lay totally flat, have no trouble breathing whatsoever, unless they have a lot of ascites pushing on their diaphragm. On the other hand, left heart failure is not CHF. This is just left heart failure due to it can be due to systemic hypertension, which will increase your systemic vascular resistance, which increases the workload because it's harder for the heart to push blood out of the aorta, thus out into the aorta, thus decreasing the amount of fluid ejected from the heart with each beat. So their ejection fraction will go down. That will keep more blood in the ventricle, causing an increase in your left ventricular end diastolic pressure, and increase in preload because you'll have more volume in the ventricle. As the ventricles are filled with fluid, blood will back up into the lungs, into the capillaries, increasing hydrostatic pressure, pushing fluid into the alveoli. When it pushes fluid into the alveoli, you'll get crackles, frothy sputum, dyspnea, hypoxia, and it can lead to pulmonary edema. And that if it's pulmonary edema, you'll have a chest x-ray that shows what's called whiteout or lots and lots of fluid. So if somebody has left heart failure, all the symptoms are in the lungs. They may have some cyanosis because they're not able to get enough oxygen in, but all the major symptoms are in the lungs. Both right and left heart failure will have fatigue. If it is due to decreased contractility, say after a heart attack, that's going to increase blood pooling in the ventricle. It's going to increase ventricular volume, or preload. And as less blood is pumped out of the ventricle, the systemic blood pressure will drop, decreasing blood flow to the kidneys. In order to increase blood flow to the kidneys, renin is released, converting angiotensin 1 to angiotensin 2, causing vasoconstriction and release of aldosterone, which will save sodium and water, increasing blood volume and their blood pressure. But it increases the workload of the heart. So it can cause fluid to back up into the right ventricle, leading to right ventricular failure and resultant biventricular failure, or CHF. It can be considered low output failure as you have a decrease in ejection fraction that occurs due to that decrease in contractility. And here's a flow sheet showing left ventricular failure after a heart attack. where it increases preload and will result in pulmonary edema. This again is just a slide reminding you of your renin-angiotensin-aldosterone system and what it does, how angiotensin 2, renin cause vasoconstriction, aldosterone saves sodium. So just a reminder. CHF is pump failure. It is biventricular failure. And so therefore your symptoms will be those of both right ventricular failure and left ventricular failure. It can be due to multiple heart attacks, cardiomyopathy, or hypertension. And this is looking at the different signs and symptoms of heart failure. That decrease in cardiac output will cause body fatigue and weakness. The increase in your sympathetic response that causes that decrease in cardiac output causes an increase in heart rate, sweating, cyanosis, and pallor. Retaining sodium in water causes edema and weight gain. Increasing venous pressure leads to increased venous congestion, and in the lungs it will cause dyspnea or orthopnea, paroxysmal nocturnal dyspnea or PND, coughing, wheezing, DOE, dyspnea on exertion. And on the right heart it will cause anorexia, nausea, pain in the right upper quadrant because the liver is engorged, oliguria because urine is not going through the kidneys, it's going peripherally into the tissues, and you'll have polyuria at night because the pressure changes will be different. And the physical signs are cardiomegaly or hypertrophy, gallop rhythm, distended necks, neck veins, hepatomegaly, peripheral edema, and ascites. CHF can also occur in children, and it is identified by poor sucking, failure to thrive, dyspnea, tachypnea, diaphoresis, grunting, retractions, sternal retractions, nasal flaring, pallor, and mottling. There's a table on page 687 for the causes and a box on and see the box on page 687 for the different signs and symptoms. A little bit more detail on CHF. High output failure is another possibility that occurs when you have normal contractility and blood volume, but you have an increase in your metabolic demand. This occurs if you have somebody who's anemic, because anemia requires the heart to beat faster to circulate the same amount of oxygen. Or if you have somebody who's septic, because the endotoxins and the bacteria cause initiation of the inflammatory response and activation of the immune response that causes vasodilatation, fever, a decrease in your systemic vascular resistance, and an increase in cardiac output. Hyperthyroidism increases your basal metabolic rate, increasing your heart rate, your respirations, and your oxygen need, thus increasing your workload of the heart, causing failure over time. Pregnancy increases demand because you're supplying blood and oxygen for 2 or more individuals. That increases the workload for the heart. And beriberi is a vitamin deficiency, which increases the demand for oxygen, thereby increasing the workload of the heart. And beriberi is secondary to chronic alcohol abuse. And this finishes part 4 of the cardiovascular alterations, and we have only one more to go.